بسم الله الرحمن الرحيم. Modes of clinical presentation of COVID-19. Coronaviruses, the family of RNA viruses in the viral order. It is a significant viral pathogen in both human and animals. Its name comes from its crown-like appearance of the virus. It has 4 classifications: alpha, beta, gamma, and delta. The human coronaviruses are alpha and beta coronaviruses. These are medium-sized viruses enveloping a positive stranded RNA. It is the very large viral RNA genome. Coronavirus can infect birds and mammals. Bats are host to the largest number of viral genotypes of coronavirus. Epidemics can occur when viruses transmit from one species to another. It can cause mutation in proteins that allow viruses to bind to the cells. In human coronaviruses are causes of respiratory and gastrointestinal tract infections. It is estimated to occur for 5 to 10% of all adults upper respiratory tract infections. There are wide variety of signs and symptoms of coronaviruses, ranging from common cold to pneumonia to ARDS. Also, some coronavirus can cause GIT symptoms, including diarrhea. When mutation occurs, coronaviruses can be a significant cause of human epidemics. This mutation can occur when coronaviruses transmitted from one species to another, or maybe an entirely new coronaviruses formed. There are 3 recent outbreaks that occur as a result of coronavirus infection. The first one occurred في 2002-2003 وده كان ظهر في تشاينا اللي هو السارس. في 2012 في السعودية في المملكة العربية السعودية الميرس، ودلوقتي الموست ريسنت اللي هو الكوفيد 19 اللي ظهر برضه في الصين في 2019. بيتعمل caused by the beta coronavirus, we transmitted from snake but more likely from bat. Clinical presentation of COVID-19. Presentations of COVID-19 have ranged from asymptomatic, mild symptoms to severe illness and mortality. Symptoms may develop 2 days to 2 weeks following exposure to the virus. The mean incubation period found to be من 5 أيام ل 97% من الانديفيدوال اللي developed symptoms بتبقى تقريبا في خلال 11 يوم من الانفكشن. الموست كومن symptoms اللي بنشوفها في حالات الكوفيد 19، اول حاجه بنقول الفيفر، ودي بتبقى موجوده تقريبا في 98% من البيشنت. الكف في 76% من البيشنت. الماليجيا والفتيج 44% of patients. الهيدك, sputum production and diarrhea were less common. Clinical course was characterized by the development of dyspnea in 55% of patients and lymphopenia in 66% of patients. All patients with pneumonia had abnormal lung imaging findings, while acute respiratory distress syndrome developed in 25% of patients. So ground glass opacities common في السي تي سكان، ودي كانت في بيبر اللي اتعملت ل 41 عيان في الوهان في الشاينا. among تقريبا 72,000 cases من الكوفيد 19 reported to the Chinese Center of Disease Control and Prevention. 81% كانوا mild، كان فيهم absent or mild pneumonia. 14% من patients were severe اللي هم بلاقي فيهم hypoxia, dyspnea، واكثر من 50% of the lung involvement within 24 hours to 48 hours. 5% were critical, where there is shock, respiratory failure, and multi-organ dysfunction. 2.3% were fatal. زي ما قلنا ان 80% من البيشنتس بيكونوا mild cases وممكن يكونوا self limiting، انما في 14% من البيشنتس ممكن to develop severe disease. الريسك فاكتور فور ذيس disease او البيشنتس اللي هم بيكونوا more prone ان هم يحصل لهم السيفير كوفيد 19 هم الادفانسد ايج، الاميونو كومبرومايزد ستيت، الدايابيتس، cardiovascular disease، hypertension، chronic pulmonary disease، chronic renal disease، liver disease, malignancy, and severe obesity. Type A blood has been suggested as a potential factor that predisposes to severe COVID-19, specifically in terms of increasing the risk of respiratory failure. The most common serious manifestation of COVID-19 upon initial presentation is pneumonia. Fever, cough, dyspnea, and abnormalities in chest imaging are common in these cases. It was found that among patients with pneumonia, 90% had fever, 70% reported fatigue, about 60% had dry cough, 40% had anorexia, 35% experienced malaise, and 31% had dyspnea, and 27% had sputum production. Silent hypoxia occurs in some COVID-19 patients when blood oxygen saturation levels are exceedingly low, yet these patients don't show symptoms of breathlessness. الكوفيد 19 كمان مش بس presenting with respiratory symptoms، انما كمان ممكن يبقى present with non-respiratory symptoms. Case series report gastrointestinal symptoms in 2 to 14% of patients, and diarrhea can be the initial manifestation of infection. Whether COVID-19 leads to such symptoms directly by infecting the gastrointestinal tract or indirectly by neurological involvement or through production of cytokines, the mechanism is still remain unknown. Viral RNA has been detected in stool samples, sometimes at high levels. This raises the possibility of fecal-oral transmission, which would have clear implications for infection control. كمان taste or olfactory disorder were noted up to 53% of the cases in a small cohort from Italy. في European study اتعملت على 72 عيان with PCR results positive for COVID-19. 74% من البيشنت reported reduced olfaction, while 69% reported a reduced sense of taste, و 68% reported both symptoms. New anosmia is being proposed as a criteria for testing, especially in young people with few other symptoms. Animal models indicate that coronaviruses might track into the brain via the olfactory nerve or bulb or both, causing neuronal damage or death. Neurological symptoms among patients with COVID-19, including ischemic or hemorrhagic stroke, dizziness, headache, musculoskeletal disturbances, altered mental state, Guillain-Barré syndrome, or acute necrotizing encephalopathy without proof of direct viral invasion into the brain. Systematic testing of COVID-19 should be considered in patients with acute neurological events during the pandemic. Cardiovascular events that have been associated with COVID-19 in preliminary observations include myocardial injury, especially in patients with severe infections, myocarditis and myopericarditis with reduced systolic function, cardiac arrhythmia, heart failure, and misdiagnosis as acute coronary syndrome. COVID-19 was associated with hypercoagulable states in a retrospective study from China, probably increasing the risk for venous thromboembolic events, including pulmonary embolism. Chest pain should therefore alert clinicians to the possibility of COVID-19. Ocular manifestations such as conjunctival hyperemia, chemosis, and increased secretions were reported in up to 32% of infected patients in Chinese cases series and COVID-19. RNA could be detected in tears. The diagnosis of COVID-19 might be particularly complicated in specific populations, say the children. Children frequently have milder disease than adults with few or no symptoms. It is not yet clear why COVID-19 may minimally infect children, lead to asymptomatic infection, or give rise to atypical symptoms that are missed by the conventional case definition. The possible reason why COVID-19 is less affected in children may be because the humoral and cellular immune development in the children is not fully developed. This may be one of the mechanisms that lead to the absence of severe immune responses after viral infection. Another reason may be because as COVID-19 viruses exploit the ACE2 receptors to gain entry inside the cells under suppression, immaturity of the ACE2 receptors in children is another hypothesis in this regard. Mental older people with infectious diseases might be harder to identify and whose symptoms could be masked. A mild pneumonia might cause only fever, cold, or confusion, leading to misdiagnosis. Diagnostic delay has serious consequences for older adults, including increased mortality and nosocomial transmission. The thresholds for testing should be lowered in this vulnerable group. The risk of transmission by people with few or no symptoms remains to be quantified. Case reports indicate that runny nose or sore throat can be isolated symptoms. Testing strategies that exclude patients with few symptoms are likely to miss a substantial proportion of cases. Similar viral loads have been documented in the upper respiratory tract of both symptomatic and asymptomatic cases, and in the pre-symptomatic phase. In one quarantine cruise ship, up to 50% of positive cases were asymptomatic or pre-symptomatic at the time of testing. The reported complications of COVID-19 have included pneumonia, acute respiratory distress syndrome, cardiac injury, arrhythmias, septic shock, liver dysfunction, acute kidney injury, and multi-organ failure, among others. Acute respiratory distress syndrome is a major complication in severe cases of COVID-19, affecting about 20 to 41% of hospitalized patients. With all reported deaths among 200 patients with COVID-19 who were hospitalized, older age, neutrophilia, and elevated lactic dehydrogenase and D-dimer levels increased the risk of ARDS and death. In Germany, post-mortem examination of 10 patients with COVID-19 revealed extensive lung pathology over time with both acute and organizing components. Non-specific and seemingly mild liver and cardiac inflammation was also found, but no CNS involvement. A separate autopsy study of 7 lungs described widespread thrombosis and microangiopathy with evidence of severe endothelial injury, compared with finding in patients who died of ARDS due to influenza H1N1. The lungs from patients with COVID-19 had significantly more microthrombi. Increasing data have shown a significant burden of cardiac injury in COVID-19. Up to 20% of patients in cohort in China demonstrated cardiac injury, often associated with more severe disease. They were more likely to be older, to have ARDS, and to experience higher mortality rates. Multiple case series have noted an increased burden of cardiovascular disease, 4 to 14%, and cardiovascular comorbidities in patients with COVID-19, often associated with increased morbidity and mortality. The risk of cardiac injury, evidenced by increased troponin levels, was up to 20% in ICU patients. Up to 12 of patients without known cardiovascular disease has elevated troponin levels or experienced cardiac arrest during hospitalization for COVID-19. The pathophysiology of injury is under investigation, but some presentations seem to relate it to the cytokine storm. As regards acute kidney injury, in a study of more than 5,000 patients hospitalized with severe COVID-19 in New York, about 36% developed acute kidney injury, 14% of whom required dialysis. The need for dialysis was associated with severe disease and respiratory failure. Take-home message. COVID-19 has a wide range of symptoms ranging from asymptomatic to severe symptoms and death. This is a look at the toll the virus takes on the body and how it progressed through a body according to the study published in The Lancet. COVID-19 leads to a multi-organ affection: the lung, heart and blood vessels, brain, eye, nose, liver, kidney, and intestine. Thank you.